Hello, it's my pleasure to be with you today in the third Lance Godsby Symposium. It's my pleasure to be with you, and I'm very thankful for Professor Tisa for inviting me to be with you today. Today I will talk about a very important topic, which is headache in children. I know that most of you are adult neurologists. However, we in the headache clinics, we might face cases for children with headache, and we have to know that headache in children is a bit different from that in adults. So we have to be aware with the differences between headache in adults and headache in children. Today I will cover these points. But before I start, I just want to invite you to have a look on my hospital, the hospital I'm working at Cairo University in Egypt. This is the Qasr al-Aini Faculty of Medicine, which is one of the oldest medicine schools in the Middle East. This is my university, Cairo University, which was founded around 100 years, more than 100 years ago, and the Qasr al-Aini Faculty of Medicine that was founded even much earlier, around 200 years ago. Qasr al-Aini Faculty of Medicine and Qasr al-Aini Hospital capacity is around 5,000 beds, so it is one of the biggest hospitals in the Middle East. This is my disclosure. To start with the epidemiology of headache in children, we have to know that around up to 90% of children reports headache, with overall prevalence of around 60% reporting some form of headaches in the past year. Headaches are slightly more common in young boys than girls, especially below the age of 7. But around the time of puberty, the ratio begins to change. If we look here to the epidemiology of headache in children, we'll find that around 50% of the distribution of headache in children is migraine, and around 30% is tension type headache. So around 80% of headaches in children is either migraine or tension type headache. However, 20% for the other reasons, whether primary or secondary headaches. And as we see here, the epidemiology of migraine in children worldwide, or the prevalence worldwide, is around 7.7%. In the adulthood, the preponderance, as we know, in migraine is towards female. However, in the younger age groups, it's almost the same, or maybe reversed towards males. Now I will start to approach a child presenting with headache. First step, and the most important step, is to take history and to examine the child. Second step is to identify the red flags for secondary headache. Then neuroimaging if secondary headache is considered. And the fourth is to categorize the primary headache disorder if you didn't find a cause for secondary headache. And the fifth step is to plan the treatment strategy. We'll cover all these steps in details. Step 1, history taking and examination. And as we know, the history taking is the most important part of headache diagnosis. And we should be aware with the very important dictum that good histories or good headache histories are taken, not given. The second thing is, when we examine a child, we should examine the child in the lab of his mother, because this is more comfortable for the child to be examined while feeling safe in the lab of his or her mother. The most important thing also, that children above the age of 5 are good historians. They can give the history of headache themselves rather than to be given by their parents. The most important pointer in the history is the time course and headache pattern, the timing of the headache, characteristics of the headache, and the symptoms associated with headache. As we see here, we have different headache patterns, like the acute recurrent headache, chronic progressive headache, chronic non-progressive headache, acute headache, the green one, and the newly daily persistent headache. These are examples for the acute headache, like migraine, like infections, like hemorrhage, like tumors, some drugs, trauma, stroke, or malignant hypertension. Episodic, like tension type headache, like migraine, like recurrent toxin exposure, like seizure, like mitochondria, or TAC. And the examples for chronic non-progressive headache, like chronic tension headache, or new daily persistent headache, or chronic migraine, or Chiari malformation, chronic post-traumatic headache, or chronic TAC. Chronic progressive, like elevated intracranial hypertension, vascular malformation, tumors, sinus thrombosis, idiopathic intracranial hypertension, Chiari malformation, or vasculitis. The timing of headache is very important as well. Morning headaches that before rising from bed might point to the raised intracranial pressure. However, the morning headache after getting up might point to the opposite, which is low pressure headache. The most important thing also is the characteristics of headache, the intensity, the character, duration, frequency, location and radiation, provocative and relieving factors, medical and medication history, family history, social emotional components involved, and finally the impact of headache on the child. Another important thing is the postural maneuver, getting up. If the getting up relieves the headache, this might point to the raised intracranial pressure. However, if the headache increases with lying down, it might point to the reverse, which is the low pressure headache. Examination is very important. First, to support your clinical impression made upon the history, and to rule out the differentials, and to adhere to many family expectations that you are taking the condition seriously and not lightly. The essential elements of examination includes the conscious level, the long tract sign, tone, power, and reflexes. Blood pressure is very, very important, and don't forget the bruit. The vision is very, very important in children. The acuity, the field, the extraocular motility, and the fundus. The fundus examination is very important. Even in very small babies and very small children, you have to examine the fundus. And if you cannot examine the fundus yourself, you may send the patient for an ophthalmologist to be examined under anesthesia. Cerebellar signs are very important, finger to nose and tremors in this artery and gait. This is very important in examination in a child presenting with headache. The second step is to identify red flags for secondary headache. If you have any suspicion that this patient might have a secondary cause for headache, like tumor, like infarction, like infection, like whatever, you have to identify these red flags, and you have to be minded with these red flags in order to pick them and send this patient for imaging, not lightly dismiss your patient as primary headache. These red flags in children might be a little bit different from that in adults. Presentation of headache in age younger than 3 years is a red flag. Explosive new onset, change in mood or mental status or school performance, underlying neurocutaneous syndrome, early morning pattern, progressive pattern. If the headache is side-locked or sight-locked and associated with symptoms of endocrinal pathology, focal neurological examination findings, if the headache is related to certain postures like lying down or getting up, headache with exercise or cough. The visual symptoms are very important red flags. Presence of diplopia, double vision. Transient visual obscurations, decreased visual acuity. The child cannot see the board in his class as before. The visual field effect and the visual symptoms not that typical for migraine aura. These are all red flags. And let us see this child who presented to me with recurrent attacks of nocturnal sweating, 4 years old male child presenting with nocturnal sweating confusion that ends up with vomiting followed by headache. Typical history of migraine that can occur once or twice per month, and he was diagnosed as migraine. However, I was very cautious and very suspicious about the history because of the nocturnal events and because of the stereotypy of the events and very infrequent events. So I asked for an EEG, and surprisingly I found these findings of occipital paroxysms. This child has benign childhood epilepsy with occipital paroxysms. This is paniatopolis epilepsy. And this table summarizes the differences between the focal childhood epilepsy syndrome that can mimic migraine like paniatopolis syndrome and migraine. We can see here that the visual aura in migraine has negative symptoms, while in paniatopolis syndrome it has positive symptoms. Autonomic symptoms infrequently happen in migraine. However, it is very typical in paniatopolis syndrome. That's why this child had sweating and vomiting as well. Loss of consciousness definitely is peculiar to paniatopolis syndrome. However, in very few examples of migraine, loss of consciousness might happen. Convulsions, of course, it is very typical for paniatopolis syndromes if it happens. However, sometimes the pediatric headache features like conjunctival injection or nasal congestion or eyelid edema, the autonomic manifestations in general might not be considered as red flag for secondary pathology because it points to primary pathology like TAC. So if we have a mnemonic for these red flags, we know that the very famous mnemonic for red flags in adult headache, which is SNOOP, S for systemic symptoms and signs, N for neurological symptoms and sign, O for the onset, O for the older age, but this is in adult headache. However, here we add Y. In pediatric headache, we add Y, which is younger age, younger than 3 years. So this is mnemonics just to remember the red flags we have mentioned before. And this is the list of the differential diagnosis of pediatric secondary headache, alphabetically arranged: alcohol, allergy, arteriovenous malformation, brain abscess, caffeine toxicity, carbon monoxide, cerebrovascular abnormality or cerebral contusion, conjunctivitis, dental, drugs, glaucoma, hydrocephalus, hypoglycemia, idiopathic intracranial hypertension, malignant hypertension, meningioma, meningoencephalitis, metastasis, neuroblastoma, osteomyelitis, otitis media, post-lumbar puncture headache, sickle cell anemia, sinus tumor, subarachnoid hemorrhage, subdural hematoma, temporomandibular dysfunction, vasospasm, and vitamin A toxicity. These are the most important causes for secondary headaches among children. We can group them into the following categories. This very long list can be grouped into categories like altered intracranial pressure, vascular causes, drugs, local causes like dental or sinusitis, and infections, and finally metabolic causes. If we come to the next step, which is neuroimaging, if secondary headache is to be considered, we'll see here the recommendations or the guidelines for asking for an imaging for a child presenting with headache. According to the American Academy of Neurology, they are recommending the following: obtaining neuroimaging study on a routine basis is not indicated in children with recurrent headaches, and normal results in neurological examination. So if we have a child with recurrent headaches with no red flags for secondary headache and the neurological examination is totally free, we shouldn't ask for an imaging. Neuroimaging should be only considered in children with abnormal neurological examination or presence of seizures or both. We should consider also neuroimaging in children with history suggestive of recent or severe headache, change in the type or pattern of headache, or features that suggest neurological dysfunction, which are the red flags. So if we have red flags, we should ask for the neurological imaging or neuroimaging. Otherwise, we shouldn't ask for neuroimaging in children on a routine basis for every child with headache. So now we should categorize the primary headache disorder after exclusion of the secondary causes, after exclusion of all red flags. We should categorize the primary headache the child has, because as we mentioned that 80% of the children have either migraine or tension type headache. So we should be aware with the criteria of diagnosis of migraine and tension type headache among children. And here is the diagnostic criteria of pediatric migraine according to ICHD-3. The criteria for pediatric migraine is almost like that of the adult migraine with two important differences. The first one is the duration. The duration here is bit preferred. It starts from just 2 hours. As we know in adults, it starts from 4 hours. Here, it starts from 2 hours. The second difference here is the bilateral location. The bilateral location here is the rule. However, the rule in adult is the unilateral, and bilateral can happen in third of cases. However, here in children, the bilaterality is the rule. The unilaterality is the exception. And this is very important difference. And the cranial autonomic manifestations in pediatric migraine can occur here in around 10 to 20% of cases, like the oral fullness, the facial flushing, lacrimation, conjunctival injection, ptosis, and nasal congestion, rhinorrhea, and periorbital edema. These are proposed criteria for migraine in children 5 years old and younger. These are not the official criteria. I just showed you the official criteria. However, I just show you these criteria in order to be aware with the some of the symptoms that we should be asked for when we analyze the history of headache in pediatric age group. Like, for example, the exercise of intolerance, the exercise of intolerance or avoidance of walking or desire to rest, the inability to eat, the sensitivity to light, inability to watch TV. These are the the questions, the indirect questions that we should ask for during analysis of headache in children, which is a bit different from the analysis of headache in adults, where we ask the direct question. However, in children, we might need to manipulate our questions in order to get the right information. And here we should be aware with the episodic syndrome that can be associated with headache in children that are called the pediatric migraine variant, or the childhood periodic syndrome, or migraine equivalent, or migraine precursors, that are the episodic syndromes that represent the prodroma of migraine, which as if the child, before getting the typical migraine, they might have before some episodic syndromes that are not that typical for migraine. That's why they are called migraine equivalent, before the typical migraine appears in later age. We might have some episodic syndromes that are associated with migraine, as we mentioned, like the infant colic, benign paroxysmal torticollis, the benign paroxysmal vertigo, cyclic vomiting syndrome, abdominal migraine, alternating hemiplegia of childhood, and vestibular migraine. If we start with the infant colic, the excessive crying in otherwise healthy and well-fed infants occur in around 5 to 20% of babies. Children with migraine are more likely to have been colicky as babies. And women with migraine are more likely to have babies with colic. Moreover, babies with colic are more likely to grow up to have migraine without aura as adolescents. Benign paroxysmal torticollis is a rare syndrome, periodic attacks of head tilt associated with nausea and vomiting. It is due to some channelopathy of the calcium channel gene, the same gene, one of the genes associated with familial hemiplegic migraine. In general, it's a benign condition with healthy toddler spells, sudden for few minutes up to hours, attacks of dizziness. The child might be unable, refuses, or frightened to walk. He might drop into the floor and might have nystagmus during the attacks. It might happen once or twice per week with positive family history of migraine. Epilepsy, of course, is on the differential, and the natural history is to outgrow the episodes after several years. The cyclic vomiting syndrome, which is recurrent episodes of vomiting that might last up to days, recurrent vomiting. And these are the criteria for the cyclic vomiting syndrome, which is recurrent episodes of nausea and vomiting with predictable patterns, normalcy in between, and self-limiting overall duration, nausea or vomiting 4 times per hour, lasting for at least 1 hour up to 10 days. Abdominal migraine, which is like an abdominal pain, sore in quality, diffuse, not localized. If it is localized, it helps to differentiate the abdominal pathology from migraine. In migraine, it is diffuse in location. Associated with pallor, anorexia, nausea, and vomiting. It might happen also in adults, not only children. And the criteria for diagnosis include at least 5 attacks of abdominal pain lasting for at least 2 hours with at least 2 of these characteristics: midline or periumbilical location, dull or sore in quality, moderate to severe in intensity. Vestibular migraine. Vestibular migraine is the second most common cause for vertigo in children after the benign paroxysmal vertigo. It affects around 9% of migraine patients. To make the diagnosis, we have to have at least 5 attacks, moderate to severe intensity, lasting from 5 minutes, just 5 minutes, as short as 5 minutes, to 72 hours, associated with current and previous history of migraine with or without aura. And these are the criteria for tension type headache and for TAC in children, and it is almost like that of adults. Finally, we have to plan the treatment strategies. We have to be smart. We have to revise the sleep pattern of the child. The meals, are they regular, sufficient, including breakfast or not? The good hydration, the activity, the relaxation, the triggers. We have to revise all these items. And for how long should our children sleep? Children from 3 to 5 years of age have to sleep at least 10 hours to 13 hours per day. 6 to 12, they have to sleep at least 9 hours up to 12 hours. 13 up to 18, they have to sleep at least 8 hours to 10 hours per day, according to the recommendation of the American Academy of Sleep Medicine. And we have to start with the dietary measures to avoid the non-dietary triggers like the chocolate, like the ice cream, like the nuts, the dairy products, the caffeine, the gluten, the tyramine containing food. We have to choose the diet based on the comorbidity like obesity or histamine intolerance, and to consider one of the known diets for migrainer patients. And the most important question now, can we use triptans in children for abortion of the headache attacks? Yes, we can use it with the following guidelines. First, we have to limit our use to 6 to 8 headaches per month, and don't use triptans within 24 hours of each other. And avoid triptans with children with history of cardiovascular or cerebrovascular disease or uncontrolled hypertension or basilar or hemiplegic migraine or in migraine with prolonged aura. And as we see here, that we can use the sumatriptan and the sumatriptan nasal spray and rizatriptan and almotriptan and zolmitriptan nasal spray. However, the starts, they are approved and labeled only from the age of 12, with the exception of rizatriptan. Rizatriptan is approved since the age of 6 years. And we should calculate our dosage according to the weight in rizatriptan. Here, below 40 kilograms, the dose is 5 milligrams. Above 40 kilograms, the dose is 10 milligrams. In acute treatment of pediatric migraine, we shall use also the ibuprofen and the naproxen according to this dose, according to the body weight, 10 milligrams per kg or 5 to 10 milligrams per kg, with the goal dose 300 milligrams. Also, in acute treatment of migraine, we might use the dihydroergotamine, valproate injection, dopamine antagonist, and some supplements like magnesium and vitamin B12. Dopamine antagonists, I mean here the metoclopramide and prochlorprazine. And also the antiemetics as acute treatment of pediatric migraine, like promethazine, like chlorprazine, and the ondansetron, and the dose can be calculated according to the body weight as well. And the preventive treatment in pediatric migraine is very important issue, and we have to be aware that in some cases we might need to have preventive treatment even with low frequency. It depends not only on the frequency but also on the severity of the attack. And these are the options we can offer to our children presenting with migraine, like cyproheptadine, tricyclic antidepressants, anti-epileptic like topiramate or valproate and gabapentin, and in all cases we have to calculate the dosage according to the body weight. Also, the propranolol, verapamil, and some selected supplements like riboflavin and melatonin and magnesium oxide, the coenzyme Q10, and the combination like B2, magnesium, and feverfew supplements. And these are the results of the very famous trial, which is the CHAMP trial that compared the efficacy of amitriptyline versus topiramate versus placebo in prevention of pediatric migraine. And surprisingly, they didn't find considerable differences between the amitriptyline topiramate versus placebo. However, they found some side effects for both the amitriptyline and topiramate versus the placebo. And now to sum up, the step one in a child presenting with headache is to take detailed history, to do an examination, to search for red flags. If we don't have red flags, we shall diagnose primary headache disorder. If we have red flags, we should proceed for neuroimaging. If the neuroimaging is normal, we have to revise the diagnosis again and diagnose primary headache disorder. We have to categorize the primary headache disorder, and we have to put our management. And thank you so much for your attention.